Great. Thank you very much for attending this webinar, and welcome and good morning, depending on where in the world you are. It's around 10:30 here in Denmark. This webinar will be partly in Danish and partly in English. Most of it will be English, but I will start saying welcome to Dr. Pete Worsley, who's with us live from University of Southampton in the UK.
Good morning, Christian. Thanks for the invitation to talk.
Great that you had the time, that Peter have the time to attend and present at this webinar together with me. It's hosted by Volturnus. It's a Danish company. I'll tell you a little bit more about, but we'll slowly start the webinar now. Before we start, I would like to mention that it's possible to ask questions, and we really like questions. So if you can find a question mark, depending on what device you are using, computer, iPhone, iPad, whatever, find the question mark and you can be able to type in a question. You can do that in Danish or English, or depending on what you prefer, and we'll try and answer the questions at least after the presentations. The agenda for today is I'll do a little bit of introduction, then I'll talk very briefly a couple of minutes about the new medical device regulation. That part will be in Danish, and then I'll give the word to Pete. I'll talk about support surfaces. I think he will introduce himself and the work a little bit more. After Pete is done, I'll try and do some examples of, you can say, a product demonstration, but it's examples of what Pete have told us about. Specifically, it will be about the IQ CX15 from Care of Sweden, and in the end we'll do some questioning and answering. The product demonstration, we are 98% Danish people, or at least people who understand Danish, so the product demonstration will probably be in Danish. Yeah. A little bit of introduction to begin with. Volturnus, who hosts this webinar, is a manufacturer of wheelchairs. It's wheelchairs like the one you see on the picture here. That's the DNA. It's almost 20 years old company. We produce and develop and keep stock and so on in Denmark, and that's basically the DNA of the company, to produce wheelchairs. A wheelchair like the one on the picture is a chair that is manufactured when we know who's going to sit in it, so it's tailor-made, made to measure. Besides producing wheelchairs, Volturnus is also a company who distribute products for other manufacturers within the rehab industry, and that's everything that surrounds the wheelchair, but it's also the pressure care area, which is handled by the two guys in the bottom corner, Michael Andresen and Ellen Nørgaard, and they represent the, you can say, the pressure prevention team in Denmark. This pressure prevention is primarily done with the products from Care of Sweden and also System, but Care of Sweden is the main, especially with mattresses, and it's also the area that we'll talk about today. Now I'll just briefly, for a couple of minutes, switch to Danish. MDR er sådan en ting, der er startet i sidste uge, 26. maj. Jeg ved ikke, om det er kommet bag på folk, men det er den nye medicinske lovgivning for medicinsk udstyr. Medicinsk udstyr, det gælder alt fra kørestole, sædepuder, madrasser, rollator. Og der er forskellige klasser for medicinsk udstyr, fordi det gælder selvfølgelig også mere invasive proteser og så videre. Kørestole og madrasser og så videre er den klasse, der hedder klasse 1. MDR, eller introduktionen af MDR, den minder en lille smule om det, der hedder GDPR, altså persondataforordningen, som der indtrådte for et par år siden. Det her det er bare omkring medicinsk udstyr i stedet for persondata. Men det er cirka lige så store omvæltninger, vi kommer til at se, specielt på klasse 1-produkter. Det handler om, det er, at vi skal have bedre sporbarhed igennem et produkts levetid. Så hvis der kommer utilsigtede hændelser, så skal man kunne gå tilbage og se, hvorfor skete den, og kan man så tage en række produkter tilbage, kalde dem osv., og man ved, hvor de er henne. Så det stiller meget store krav til kommunerne i Danmark, der har med genbrugshjælpemidler at gøre, som mange af de her klasse 1-produkter jo er. Det stiller også store krav til producenter og distributører som os, men producenterne får også meget større krav, fordi at udover at man skal have sporbarhed, så skal man også have en bedre dokumentation for, hvordan ens produkter virker. Og det er egentlig derfor, vi holder det her webinar i dag, det er, at MDR kræver den her dokumentation. Det kræver egentlig, at man har lidt mere forskning ind bag de produkter, som man går ud med, og når man siger A, jamen, så har man dokumentation for, at A er rigtigt. Altså det, og det betyder egentlig, at man skal lave nogle mere klinisk evidens. Og når det kommer til madrasser, så er Care Sweden rigtig, rigtig gode til det, og det er derfor, vi er glade for at arbejde sammen med dem. Og det er det her webinar egentlig et eksempel på. Yes, now I'll switch to English again, so a bit more people understand. But the reason for this webinar, and it's very important to have clinical evidence of how different products work and why they work. And before I give the word to Pete, I'll pull up one study from a Belgian research group where they did experiments on a mattress similar to the one next to me, and the one Pete will talk a little bit about as well, and I'll do a product demonstration afterwards. In this study, they looked at 10 Belgian nursing homes, 40 residents, and they swapped them all from an alternating mattress to a pulsation mattress, and it was basically an observational study. But some of the results you can see here is the overall comfort on a pulsation mattress is very high, 8 to 9 out of 10, which also meant that they slept quite well. So the sleeping quality was very high, and actually most of the people, or 80%, preferred the pulsation mattress, even though when you switch one mattress to another, then the change is never something people changes is not something we like in general, but 80% like this change, so that's very, very high. So it says a little bit about the comfort. This kind of study shows a little bit about how the organism works together with a product, which is in this case the mattress. It will show a little bit more about how why you can say the organism reacts like it does. One last slide before I give the word to Pete is just to show you a little animation of what's the difference on an alternating mattress compared to a pulsation mattress. The alternating mattress, when you have an air mattress, means that the differences in air pressure in the chambers next to each other varies a lot, where in the pulsation mode it's much less variance. So we don't change so much in the pressure inside the mattress, and that is the difference on the alternating and the pulsation mode. In the end, I will now I'll try and give the word to Pete. Last night I was sitting preparing for this webinar, and then I found this old picture of Pete, because it happens that Pete and I shared an office here in Aalborg University when I think both of us was PhD students. And this picture is actually from I think we met in Spain and played a little bit of tennis. Pete definitely won that match. So yeah, with that, I will give the word to Pete, and I will just change the presenter. Yeah, now I think Pete should be the one presenting.
Can you see the screen, Christian?
Yes, it's perfect.
Perfect, lovely.
See you and the screen. So give it away.
Thank you. I think a good job you didn't have a panned out image of that tennis match, because the professor that we were both working under at the time forgot his shorts, but that didn't stop him from playing tennis with us. So I'll let everyone paint their own mental image of that. But yeah, all in good fun. So thank you for the invitation to talk, Christian. So my name's Pete Worsley. I'm a physio by background, but I did a PhD in bioengineering, so I work across health sciences and engineering. So I spent some time with Christian in their engineering department in Aalborg. But for the last 10 years, I've had a big focus on skin health. And that really came about through working with Professor Dan Bader, who came to Southampton in the UK and set up a skin health research group. And this work is really a product of myself, Dan, Dr. Sylvia Kagigari and Sarah Fryer, who were both PhD students with us. So the main focus is really looking at support surface evaluations, and also having a look at future perspectives on how we can perhaps monitor individuals and improve pressure ulcer prevention. So just as a bit of a backdrop, in Southampton, we have a big university campus, which is on sort of the top left of the slide, but we're actually based in a hospital site. So we have a clinical academic facility that was set up to support clinicians to do part-time PhDs and work part-time clinically. So we're very much wanting to do translational research that's going to have an impact on patient care. And a lot of our research questions and research ideas come from active clinicians and patients from the forefront of practice. So I'm sure you're all well aware, but if we just remind ourselves of the international definition of a pressure ulcer, so they're a localized injury to the skin and or underlying soft tissue, usually over a bony prominence, and they result from an exposure of pressure or pressure in combination with shear. And there's lots of different situations where this can occur. So traditionally, we always affiliated pressure ulcers with people that are lying in bed or sitting in chairs for prolonged periods. But we now know that lots of people get pressure ulcers from things like medical devices, prosthetics, orthotics, ventilation masks, anything that's attached to the skin surface. And perhaps what the most important thing to consider in terms of the causal factors in pressure ulcers is that there's a relationship between the amount of pressure, the magnitude of the pressure, and the exposure time. So very high pressures will result in skin damage in a matter of minutes. However, lower pressures can be tolerated for prolonged periods, but if the skin and soft tissues are continually exposed, ultimately, often people do develop pressure ulcers over time. And that sort of red sigmoid line can move up and down depending on the individual's own susceptibility, so their comorbidities or their health status. And just thinking about that, this is a schematic that was published by Suzanne Coleman a few years ago, but it nicely conceptualizes the risk factors. So at the top, you have the mechanical conditions, so the magnitude of the load, the duration in which it's applied, and what's that type of load? Is it pressure and shear? How's that pressure distributed? And then on the bottom of the schematic, you have these factors that all contribute to someone being susceptible for skin damage. So do they have changes in their tissue properties or the morphology or geometry of their tissues? Do they have altered physiology, so from an underlying condition like cardiovascular disease or diabetes? And this all plays into the sort of the damage threshold where someone might be at risk of getting a pressure ulcer. So the primary strategies to prevent pressure ulcers come in the form of reducing the pressure magnitude and trying to create a pressure profile that's most sort of friendly to the skin surface, and to minimize the duration in which the pressure is applied. So if you think about this conceptually, you've kind of got three main kind of interventions. To affect the type and magnitude of pressure, you can put people in an optimal posture, and you can give them a support surface which redistributes the pressure as evenly as possible. And to reduce the duration, you want to regularly mobilize patients, so promote active turning cycles, promote them coming on and off support surfaces. If it's a device, you need to try and remove it regularly. And there are support surface technologies that can also provide some offloading, so things like the alternating pressure or pulse mode of a sort of higher specification air mattress will periodically offload the tissues. And I think perhaps what the field has been missing for a long time is perhaps with our nursing colleagues, tissue viability specialists, there's been a lot of focus on the support surface. And then with our allied health professionals, they tend to focus a lot on posture and mobility. And perhaps in a lot of care settings, not all, there hasn't been the sort of joined up thinking that's really needed to provide quality prevention strategies. And for example, when you do a randomized control trial of a support surface, and you just want to compare mattress A versus mattress B, if you don't control or monitor posture and mobility, you're going to find it very hard to find a difference in the mattress types because you're missing 2/3 of the picture. So as a research group, we've worked with a number of different companies and also had external funding to really try and better understand support surface performance. So do they actually do what manufacturers are claiming? How can we assess their efficacy? And can we support clinicians in decision making? And this is a quote from a chap that had worked in industry. He's retired now, but he'd been with the support surface injury for about 20 years. And he said to me, when I started working 20 years ago, I thought we would have eradicated pressure ulcers in 5 years. So again, I think there's a real commitment from industry to try and improve pressure ulcer prevention. But perhaps then there needs to be lateral thinking about how we can go beyond just looking at support surfaces and looking at sort of the wider care packages. So as a group, we've published a number of times focusing on these performance characteristics. So typically within support surfaces, you'll have claims of pressure redistribution. You'll have claims perhaps of microclimate control, so some sort of element of temperature and humidity control, and claims of perhaps tissue perfusion or some change in tissue physiology. So within a lab-based setting, we've got a number of different tools we can use to characterize each of those parameters and assess those parameters with different support surfaces, and in particular when individuals adopt different postures. So I'll just talk a bit about a recent Care of Sweden study we undertook. So we were approached by Care of Sweden, and obviously they have a pulsating mode, which is perhaps going beyond some of the more traditional alternating pressure and continuous low pressure modes. And they really wanted to understand, did the pulsating mode make a difference in terms of the pressure, local tissue physiology, and was there any microclimate effect as well? So we did a study design. We often use what we call a randomized crossover design. So we have volunteers coming into the lab. They all get tested across each of the support surface settings, across different postures, and we randomize the order to minimize the bias between each of the test sessions. So for this study, we used a real big range of participants, from 18-year-olds all the way up to 90-year-olds, to try and get a representative range of individuals. We looked at them across the continuous low pressure mode, the alternating pressure mode, and pulse mode. And the three postures we asked them to adopt were supine, a 30-degree lateral tilt, which is something you'll often see in practice to offload the sacrum, and a 45-degree high sitting mode, which again is indicative of a more functional posture, perhaps when people get sat up in bed to have lunch or to talk to relatives. So again, what you often see within some support surface evaluations is they'll look at perhaps a single posture, for example, supine, and often you can get very good results just from having someone lying flat on their back. But actually you want to have something that's far more representative of practice. So having lots of different postures is really important. And we use lots of different tools. So in terms of trying to assess the performance, we obviously asked individuals what their comfort was, how well supported they felt, how firm they felt the support surface was. We had sort of biomechanical assessments of interface pressure using a Foresight PT from X sensor. And we also measured the positions the patients were in using an inclinometer. So how tilted was the pelvis during that 30 degrees? How tilted was the trunk when the head of the bed was raised? And we like to combine those measures with local physiology as well. So as a group, we fairly extensively used transcutaneous tissue gas tensions, and that's a small sensor that can be attached via a ring to the skin surface. It heats up the local skin, and through diffusion it can then measure local oxygen and carbon dioxide at the skin. And we measured that at two sites, at the sacrum, which is an area obviously of interest for pressure ulcers, and a control site in the shoulder. And this really gives us a surrogate measure for ischemia. So we know occlusion to the local blood supply is one of the primary causes of pressure ulcers. And through the transcutaneous measures, we can actively see whether or not the tissues are compromised. And we also measured temperature and humidity. So there's been quite a lot of interest in microclimate, so whether or not mattresses and cushions can reduce temperature and humidity at the interface. So we have little combined sensors that we place across the support surface to measure the microclimate. So this is the sort of thing that we get back from the data. So we can measure in simultaneously the pressure values, so they all get measured once per second, and we obviously get the contour map of the pressure profiles from each individual. And we look at some key outcomes like obviously peak pressure, but also peak pressure index, which is an average of sort of a 9x9 cell region of interest contact area, as well as looking at things like the center of pressure. And then from the transcutaneous data, we get an indication of oxygen and carbon dioxide, but we were also able to monitor the internal mattress pressures as well of the support surface system. And what was really interesting on the bottom left-hand side, the blue is transcutaneous oxygen and the orange is the internal mattress pressures. And what we saw during the alternating and pulsing mode is that the oxygen actually increased and decreased uniformly in time with when air cells were inflated and deflated within the alternating and pulse mode. And that really tells us, or is indicative, that actually the support surface is having a direct effect on local tissue physiology. So you can actually see when you alternate the mattress, it's actually increasing and decreasing local perfusion and trying to maintain a healthy state in the tissues. And what we do with the transcutaneous data is we apply a criteria. So we measure oxygen and carbon dioxide simultaneously, and we then categorize that information into three main sort of trends of perfusion or ischemia. So the first is that the oxygen remains nice and high. This is category 1, and the carbon dioxide remains nice and low. So that sort of tells us that the tissues are perfused. In the second case, oxygen will reduce, but carbon dioxide stays low. That's a category 2 response. And in the ischemic state, what we see is the oxygen reducing. So this thick line that's gone all the way down to 0 at the bottom, and the dashed line, which is carbon dioxide, going up and up and up towards 80. That's category 3. So a reduction in oxygen and an increase in carbon dioxide, showing the local skin and cells have gone from an aerobic state to an anaerobic state because they can't get the local blood supply. What we saw across all the testing is the vast majority of individuals maintain their tissue perfusion. So we saw a nice bit of tissue perfusion across all postures and in all states. The postures which probably created the largest amount of local ischemia and one category 3 response were things like high sitting. But again, you're changing the pressure profiles, you're perhaps introducing additional shear at the sacral site and pressure, where you're reducing the contact area and focusing it on the buttocks and sacral site. But what we did see, certainly with the pulsating mode, is that we had no category 3 responses, and that for the vast majority of participants and postures, the tissues were very highly perfused. So we can have confidence that actually the mattress is providing a good level of pressure redistribution, and as a result, the tissues are remaining in this perfused, healthy state. And for things like the pressure values as well, generally interface pressure values remained low. Certainly across all the participants, peak pressure values were less than 70 millimeters of mercury. And sort of when you look at the averages, they're going from sort of 30 to 40 millimeters of mercury for the peak at the sacrum, thorax and heels, and the peak pressure index at around 20 millimeters of mercury. So it seems like there's a pretty effective distribution of pressure across the surface. Unsurprisingly, when you look at things like pressure gradients, so that's where you look at one cell of pressure adjacent to the next, so whether or not you see a sort of a peak in the pressure. At particular bony prominences like the heels, you see the highest pressure gradient, but values at the sacrum and the thorax were very low. So again, there didn't seem to be any particular pronounced pressures that were high over one bony prominence and sort of low in the adjacent areas. So we're pretty, again, in terms of an outcome of pressure distribution, these were very positive across each of the different mattress settings and for each of the postures. And in terms of microclimate, what we saw here is that the interface pressure increased typically to around about 35 degrees. And again, this is indicative of obviously the individual creating their own heat, the heat at the skin surface. And obviously that creates a reasonably hot and humid microclimate at the mattress individual interface. And perhaps the most interesting finding here is that actually posture had the greatest effect on microclimate. So it wasn't necessarily the support surface mode, it was actually posture. So when you put someone into lateral lying, it actually created a reduction in temperature. Although we didn't see those same reductions in relative humidity, those values stayed at around about 40 to 50%. So the other part of the talk I just want to briefly mention is going on to repositioning. So often you'll see in guidelines that they recommend people are repositioned sort of every 2 to 4 hours, but this often doesn't accommodate the individual's need. So often people are more or less mobile than others, and you need to have a personalized approach to repositioning. And what we saw in the hospital setting when we talked to the tissue viability specialist is that they had a turnaround promotion project where they moved everyone every 2 hours in bed. But then when we looked at the notes, patients were moved into the chair and left for 6 hours or 8 hours out of bed. And unsurprisingly, people were still getting pressure ulcers. And And we also did a project with clinicians. So we asked 8 experienced clinicians to put a patient into a 30-degree tilt. And as you can see as in the image at the bottom, there was a huge variation in practice. So actually there's a significant need to educate and inform clinicians about effective repositioning strategies, where to put the pillows, how to offload tissues effectively. And perhaps where research can support that is really looking at how technologies can monitor patients and promote better posture and mobility. And we know that sensing technology can improve the provision of turning. They can reduce the rate of pressure ulcers in a recent study. And perhaps the most important thing for these technologies is actually they give feedback to the patients, the carers, and the healthcare workers to improve their own awareness, their adherence, and particularly perhaps in the community setting, when you monitor patients effectively, you can then give them access to professional resources more efficiently. So those that are moving less perhaps might get access to more carer support. So we've done a lot of work trying to look at different monitoring technologies. So we've used things like body-worn sensors like accelerometers, and we've also used continuous pressure monitoring. So X-Sensor make a continuous pressure monitor called the Foresight PT and the SS seating interface. And we've used that to try and create a surrogate for movement using these different sensing technologies. And Sylvie Cagliari, one of our PhDs, did a lot of the early work in terms of collecting the lab-based data and clinical data and using things like machine learning to train a model to detect posture and mobility. We've done a number of different clinical evaluations. So we did a large 4-center trial in the community called PROMISE, Pressure Reduction Through Continuous Monitoring. That was funded by the Health Foundation and led by a tissue viability nurse called Nikki Elward-Watton. And we've had a clinical academic nurse working in a spinal cord injury unit in Salisbury in the UK, who's monitored patients both in the inpatient setting and when they've been discharged home. So Sarah monitored spinal cord injured patients with differing levels of injury, both in terms of the spinal level and their ASIA score. And she monitored them for 72 hours, twice in the hospital and twice when they went home with these two X-Sensor pieces of technology. Perhaps what was really startling for us is when we gathered Sarah's data and we used Sylvia's algorithm to predict the frequency of movements and the maximum duration of time between movements, we saw a very linear trend between what we used a spinal cord function score, which is a composite of their ASIA score and their spinal level of injury, and these movement profiles. So those with the lowest SCI function score, typically with an ASIA D plus a high level of injury, so a limited mobility, the posture and mobility monitoring system was able to differentiate those individuals, perhaps from those that have a lower level of injury and less severe ASIA score. And that's probably what you'd expect, because spinal cord injured are quite a specific group with their own specific sort of functional impairments. But then when we plot those that didn't get a pressure ulcer, we start to see some trends in terms of clusters of individuals. So those with the lowest frequency of movement and the maximal intervals were the ones that got the pressure ulcers, plus one individual that was a very high frequency mover. And again, there's some data that's recently come out of the group in Dublin, which shows those that are at the extremes of low movement and high movement might be those that are most at risk. So just to summarize, there's test methods out there that can characterize the performance of support surfaces, and the pulsating mode of care of Sweden performed very well across a range of these measures. Posture and mobility are key to pressure ulcer prevention, although there's limited guidelines in terms of best practice. There's a real opportunity for support surface companies and technologists to create solutions to support patients, carers, and clinicians to try and help them monitor their own posture and mobility. And hopefully, you know, as these technologies become more available, they can be integrated into systems to help promote personalized care. And that's my lot. Hopefully I haven't run too far over time, Christian.
Great, thank you very much. No, it's perfect.
Sorry.
Yeah. Okay. I think we swapped the presenter now, and I'll start. Actually, I'll start switching to Danish, because I'll do a little madras presentation, and it's probably more interesting for the Danish audience. Ja, så jeg vil starte med lige at lave en madraspræsentation her. Den madras, der hedder IQ-CX15. Det er den, jeg har liggende her ved siden af mig. Jeg tror, vi kan starte i pumpen, kan man sige. Den hænger her. Pumpen er sådan en intelligent pumpe, kan man sige, som der er ikke så mange knapper på. Den er selvfølgelig koblet til madrassen her i siden med hvor CPR-ventilen sidder i selve interfacet der. Hvis man ser ovenpå, jeg håber I kan se det her, så er der faktisk kun 3 knapper her. Så man kan ikke vælge det ene og det andet og det tredje, for den kører altid pulsation mode, som Peter snakkede om, altså den pulserende. Det her med, at der ikke er så stor forskel mellem det lave tryk og det høje tryk. Den er også så intelligent, at den selv finder ud af, hvad patienten, der ligger på madrassen, vejer. Så den vejer selv ind, hvad patienten vejer, og den finder også selv ud af, hvad man kan sige liggende stilling patienten er i, og så korrigerer den madrassen efter det. Så hvis man ændrer stilling, altså laver lejring om, så korrigerer den og indstiller sig til det. Det vil også sige, hvis man er siddende, altså hvis man hæver hovedgærdet og sætter sig op for at spise eller sidde i sengen, jamen så registrerer den det selv og fylder mere luft i. Og specielt den pulserende mode, som den her altid kører, det så vi jo i Pete's resultater, at i siddende stilling gør det ret stor forskel. Måske fordi at arealet man egentlig sidder på er ret lille i forhold til hvor stort man kan sige hvor stor effekt tyngdekraften har på os. Så når man sidder i en vekseltryksmadras, så har man ikke helt så meget areal, fordi der er nogle af de her kamre, de er jo uden tryk nærmest, ikke? Hvor den pulserende, den bibeholder lidt mere tryk i de kamre, som ikke har så meget tryk. Det lyder kompliceret, men det er det måske ikke helt så meget, som det kan lyde. Men den er lavet ret enkelt, fordi at den tager hensyn til det hele selv. Der er en knap i midten, der hedder max, til en plejefunktion. Og så er der en knap, hvis der skulle komme nogle alarmer, så kan man slå dem fra. Og så har den en enkelt knap, der er meget relevant i de her covid-tider, pack and go, og den suger luften ud af madrassen, så man ikke skal ligge ovenpå den, og egentlig på den måde minimere risikoen for at sprede virer og bakterier osv. Så det er sådan set pumpen. Der er selvfølgelig nogle andre features, som vi har ikke så meget tid, og det er nogle af tingene er lidt svært at gå igennem, men pumpen kører på 12 volt, så selve ledningen er en 12 volts ledning, så hvis den kommer i klemme i sengen, så sker der altså ikke noget ved det. Der er ikke 220 volt igennem sengen, så jeg lige prøver vi lige at skifte lidt over på madrassen, for at vi lige hurtigt kan se, hvordan den egentlig er opbygget. Vi kan lige prøve at lyne lidt op her. Så skulle I gerne kunne se, at madrassen er opbygget af selvfølgelig et betræk ovenpå, og så er der de her luftceller. Nedenunder luftcellerne, der er en sikkerhedsmadras, og den er også af luft. I det her tilfælde hedder den CX15, så er den 15 cm høj, og sikkerhedsmadrassen er de 5 cm, så toppen er 10. Det nederste i madrassen her, som er hælezonen, der er de lidt mindre for at give lidt mere aflastning til hælene. Selve cellerne er indkapslet af sådan et stykke spilerdug, kan man sige, så man ikke kan falde ned igennem dem, så der er god stabilitet i det. Og samtidig så meget af den forskydning, der vil komme i, når man bruger sengens funktioner, det bliver taget imellem madrassen og betrækket, kan man sige, fordi at der er meget lav friktion der. Det var sådan en lidt hurtig gennemgang af madrassens funktioner, kan man sige. Jeg tænker, jeg kan være med her på billedet igen. Det er sådan, at det her madrassystem, den her madras, jeg lige har fortalt om, den hedder IQ CX15. IQ, det er pumpen, og madrassen er den, der hedder CX15. Der findes også en CX20, der er 20 cm høj, og en CX10, som er en 10 cm topmadras. Det er sådan, at man kan også bruge andre pumper, fordi hvis man, Pete han snakkede lidt om pulsation mode og den her alternating, altså vekseltryk, og så den konstante lavtryk. Og der findes en pumpe, der hedder A4, og den går på samme. Man kan faktisk bare skifte den over, så finder pumpen selv ud af, hvad for en madras den er koblet til. Og den har altså de forskellige modes, som man kan vælge. Så der er en masse forskellige valgmuligheder i den her. Det er noget lidt specifikt, altså det er noget, man kan bruge i specifikke situationer, men langt de fleste gange er den her IQ-pumpe alt rigeligt, og så mindsker man risikoen for at lave nogle indstillinger, som man måske ikke har helt styr på, og det skulle gerne mindske risikoen for utilsigtede hændelser og så videre. Som alt sammen er noget, hele MDR-delen har stor fokus på. Nu vil jeg lige dele en afsluttende kommentar her. Fordi jeg snakker lidt videre på dansk, men det står på engelsk. Take home message i dag, det er, at jeg har prøvet at lave en lille oversigt over MDR. Jamen det betyder, at der er mere fokus på klinisk evidens, altså vi skal simpelthen lave noget forskning, som støtter op omkring produkterne. Det her pulsation mode, jamen det giver en høj komfort og et godt blod, man kan sige god blood flow, altså god blodgennemstrømning, og så samtidig at de her intelligente madrasser, eller man kan sige liggeflader, jamen det er lidt fremtiden, men en del af fremtiden, den er her allerede i sådan en IQ, for eksempel CX15 eller CX20 madras, fordi at der ligger så meget intelligens i den, at den reagerer på posituren, som er noget af det, som Pete viste, at har kæmpe stor indvirkning både på mikroklima og trykfordeling selvfølgelig. Nu skal jeg lige se, om jeg kan komme herover. Det kan jeg ikke. Så. En lille teaser. Efter sommeren vil vi lave et MDR-webinar, der kun omhandler MDR. Og hvis man gerne vil holde sig opdateret, så kan man gå ind på vores hjemmeside og hoppe ind på eller og så tilmelde sig nyhedsbrevet. Ikke? Vi har ansat Tina sidste år, eller hun har arbejdet her flere år faktisk som studerende, men hun blev færdig sidste sommer og har arbejdet et års tid nu som det her Q&A manager, altså står for alt, der har med regulatorisk og MDR og så videre. Så Så hvis der er spørgsmål omkring det, så er jeg sikker på, at vi altid er klar til at svare på det. Men ellers så vil jeg sige tusind tak, fordi I lyttede med, og så har vi lige et par spørgsmål, eller der var i hvert fald et enkelt spørgsmål, der er meget let lige at komme til at svare lidt på, kan man sige, eller vi kan snakke lidt om. Det var egentlig, hvad der giver størst effekt trykfordelingsmæssigt, om det er pulsering eller den klassiske vekseltryk. Og det svar, jeg måske synes, vi prøver at tage op der, det er, at der er altså størst trykfordelende effekt, det er jo lidt, det kan være mange ting, men altså, der er ingen tvivl om, at peak-trykket det bliver mindre, når man vælger pulsation eller pulserende, fordi at man ikke har helt så stor forskel. Så man har lidt større liggeflade, og det giver også et lidt mere ensartet tryk, altså mindre trykforskelle, som er noget af det, som danner shear og er en risikofaktor. Yes, but Pete, are you still with us? Then I'll in the end switch to English again and say thank you very much for listening, and thank you very much for Pete for joining this webinar. I hope that everyone found it interesting and informative. We will be sending out emails after this presentation is done, where there will be a link to the presentation, and you can go back and see the more complicated parts again.